right. So what we got tonight is we have this program. As you know, the title is MS in the Black Community, and I thank you for being here for this. We have two sponsors for tonight's program. We have Novartis and we have TG Therapeutics, and we should give them a round of applause and say thank you. All right, great. Dr. Rosenthal is going to speak for a while on topics. Well, you see them right here, right? And then Damian Washington, who's a patient advocate. If you don't know him, you guys have missed out because he's been very busy in the MS community for many years. And then he and Dr. Rosenthal are going to have a conversation on different things. And then after that, we'll do Q&A. Dr. Rosenthal, come on up. Let's get this thing started and get going. Thank you.
Thank you so much for coming out tonight. All right, so we're going to talk about MS in the Black community tonight. Some of the topics we are going to discuss are shared here. We're definitely going to talk about access to care, equitable healthcare disparities. We're going to talk a bit about clinical trials and diversity in clinical trials. And I'm going to talk about MS specifically in the Black community, about what we know about it so far. So I thought I would start off with a couple quotes that really impact the importance of, or the impact rather, of access and equitable healthcare right now. These quotes are all from men and women of color. So first from Dana Bowen Matthew. She's dean and professor at GW Law. And she says, implicit bias is the single most important determinant of health and healthcare disparities. We're going to talk about bias as part of this. And unfortunately, it does have a huge impact in so many decisions, but it does impact healthcare significantly. Next, from Amina J. Muhammad, she's Deputy Secretary General of the United Nations. She says there is no one size that fits all. We must work country by country, region by region, community by community to ensure the diversity of needs are addressed to support each reality. And I like that because even within the Black community, there are a lot of different realities, and we need to take that into account when we look at access and equitable healthcare. And then last but not least, we've got Martin Luther King Jr., who says, and I'm sure you've all heard this before, but of all the forms of inequality, injustice in health is the most shocking and inhumane. So again, these are big issues that we really want to highlight and try to bridge the gap in a lot of these ways. So as we talk about barriers to diagnosis and treatment, health inequities. So when we talk about inequities, we're talking about our access to different portions of healthcare, practitioners, services, and that access that inability to access is going to be usually associated with social disadvantage. And it's these inequities that lead to disparities. So disparities are going to be those outcomes that are differing in a certain group of people. And it's not due to the disease process itself. It's due to these external factors that really should have no bearing on the disease state. We talk about race a lot, right? And we know what does race mean? It's a social construct. But why is it still relevant? It's relevant because we see minorities, racial minorities that are overrepresented in the socially and economically disadvantaged groups. So as long as that still remains relevant, race itself is going to remain relevant in this particular conversation and many others. So looking at some of these barriers to diagnosis and treatment, lack of insurance is going to be a big one. If you look at Black MS patients in particular, they're less likely to have private insurance. So that's going to directly impact access. Whether or not you have insurance is going to impact your ability to have certain treatments, engage with certain types of therapies. Huge impact. Lower income. Finances are a big deal. And beyond just maybe affording your treatments or whatever other therapies are involved, without necessary income, it's hard to even take the time off of work. Not everybody has paid time off. Taking care of your needs at home, childcare, if you're taking care of a parent, all of these things go into it and are going to impact someone's ability to access care. Higher disability. If you have higher disability, if you're living with MS and you may have difficulty just navigating, getting out of the house, getting down your steps, beyond just living in a rural community, the hospital could be across the street, but if you can't get out of your house, how are you going to access care? And then with higher disability too, sometimes comes more of a higher need for income to access the services to help you navigate all of this. So it's all related. Lower health literacy, we'll talk a little bit about that. Language barriers, negative illness perceptions, discrimination and bias. So all of these things are going to impact access. Lower access to care. A lot of patients that are going to be affected by these barriers too get incorrectly labeled as being non-compliant. And it's not that they're just not taking their treatment or not showing up to their appointments. It's these barriers that are in place that are directly impacting that. And then research. With lower access to care, we see lower participations in research. So next, I'm going to talk a little bit about social determinants of health. This has been a more popular term. It's been coming up a lot more lately. And social determinants of health, really we're talking about the factors that influence health, where you live, where you work, where you grew up, all of these things that impact how you relate to healthcare. And this particular graph comes from a study that looked at social determinants of health in the Black and Hispanic communities. And what they found was a lot more economic instability. Education levels were lower. And again, when that impacts health literacy, it leads to like a less or poorer understanding of the MS disease itself, which is going to be important as you're navigating this illness. We look at social and community context with there being a higher negative illness perception or poor lived experience of MS. And when I think about that, there's a lot of people out there with MS that are talking about, living your best life, thriving with MS. What we're finding is that this community of people aren't able to do that. They're not able to live the best life that they can because of these problems. Health and healthcare. So lower access to specialty care. We know that from research that we have available that when Black MS patients make it to that specialty care, they usually present with at a point where they're already having disability compared to the white counterpart. We see Black MS patients that are less likely to be on disease-modifying treatments. Looking at that too, differential utilization of services. This is a big one. Services are really helping with that quality of life, right? We see Black MS patients that aren't using Medicaid as much as their white counterparts. We see patients not using case management service. So raise your hand here if you've used case management before. So that's telling right there. So case management is really important to help coordinate care, sometimes coordinate referrals, find, sometimes copay assistance, bridging that gap in some of those things. Maybe you don't live in an area that has certain specialties and you need some assistance in coordinating that. So it's someone really to just kind of take ownership and help you navigate these things. It's really important, and it does help to live a better life with multiple sclerosis. We see different utilization in equipment, technology, and modification services. Again, these are things that help you get through the day, do the things you want to do, work, interact with your family, go on vacation, okay? Big quality of life issues and less utilization of nursing services. So with health literacy, what I mean by health literacy is someone's ability to take in information and understand it to the point that they're able to use that information effectively to promote and maintain or obtain good health. And this is another area where we see disparities. So health literacy can vary by race, ethnicity, age, income, language preference, and education. And so some examples of this are going to be just basic medical terminology, and we throw a lot at you guys from an MS standpoint. Is it a exacerbation versus a pseudo-exacerbation? And then we have, the audacity to have flare, exacerbation, and relapse, which really mean all the same thing. We should just pick one word, but we use three, and then here you are thinking it means three different things. So it's confusing, and so you have to know that information and be aware of that, or else you're going to be lost, right? Who here knows the difference between a generic and a biosimilar? That's another one that's coming up more and more, right? So just so you know, generics are going to be identical to the brand name, or supposed to be identical to the brand name within a certain amount. Biosimilars, not identical, but similar. And so because of that, they have to undergo some additional testing. But both of these generics and biosimilars, because we have treatments now that have been out a certain period of time, they're becoming more prevalent. And so you may have your neurologist or someone talking to you about that as it comes up, and you want to be able to know what they're talking about. So there's a lot of educating yourself about medical terminology is important. Prescription drug directions, knowing how to take your medication correctly, or what do you do if you ran out of medication for 2 weeks? Can you just start it back? So that's important. Health insurance, again, a lot of terminology there. In network versus out of network. What is your out-of-pocket, deductible. What if you change insurance and you didn't realize now that the neurologist you've been with for 20 years is out of network, right? So being able to navigate all of that. Research and consent forms, they really need to be written in a way there's guidelines that they be written in a way where it's understandable at I forgot what grade level it is, but it's supposed to be easily understandable. It's very difficult sometimes, but of course with that, it makes it difficult for individuals to feel comfortable participating in research if they have difficulty understanding these forms that we're giving you. And then again, the utilization of services, knowing that they exist and how to utilize them is important. So as you talk about access, inequities, and disparities, this does impact clinical trial participation. So we're going to talk a little bit about clinical trials now. All right, so why are clinical trials important? This provides the best information on the effectiveness of various treatments. Clinical trials really are looking at two things. It's looking at safety and it's looking at efficacy, so how well something works. And that something is any type of intervention. It could be a medication, it could be a device or a specific type of therapy. The clinical trials, they first look at safety, which makes sense because they're going to look at lower numbers. By the time we get to our larger clinical trials, leading up to drug approval, this is when you have studies with thousands of people. Safety's been established, and they're really looking at effectiveness. And the design of these clinical trials are in such a way that they are able to control for different variables so that at the end of the day, you know that any difference between these two groups are due to that particular treatment. And so we rely heavily on that as doctors and neurologists and how we look at the way a medicine or a certain intervention works. So as it stands now, clinical trials, less than 10% of clinical trial participation is coming from minorities or a Black minority in particular. And that's across the board for all clinical trials. If you look at MS studies, it's much lower. We're in the range of 2 to 5%, so very low. And so that is where we're lacking that representation in research right now. So this is, again, just highlighting that. So for example, the US population in 2019, this is a little old data, but 13.4%, and we see 9%, again, that's for all clinical trials that are Black or African American identified. This study is really just showing that there hasn't been a whole lot of change over the last few years, okay? So the lack of representation has been fairly steady. And this slide is highlighting that it's not just in neurology. If you look across the board at different specialties, representation is often an issue. So why is diversity in clinical trials important? So if you look, a lot of patients ask, how did this happen? How did I get MS? And we rarely give you like a good answer, right? It's because it is very complex and we don't know 100%, right? So we know that there's a genetic predisposition. We know that there are geographic and environmental factors that contribute as well. And so we need diversity because geography, ethnicity, race, all of these things contribute to disease susceptibility. So we need everybody included in these studies. We know that the natural history and response to treatment could potentially differ between different racial and ethnic communities. So we're looking at what genetic factors are going to influence disease. We want to know, do all types of people respond to treatments the same way or not? And then we have to keep in mind, how much is social and economic disadvantage contributing to differences in outcomes versus actual biology? So to conclude this slide, in order to accurately apply clinical trial results to all patients, we need to study all patients. Okay, so what are we learning about our Black MS patients? So this is a study looking at the prevalence of MS out of a clinic in Southern California. Prevalence meaning how many people have MS at a given point in time. The big takeaway here, if you look at the second half, is that there's not a huge difference between Black and white individuals living with MS. Of course, we see more women with MS, and that's known that women are going to be affected more. But Black and white individuals are fairly similar, whereas Hispanic and Asia Pacific Islander are having less or a lower prevalence. So this really argues against that kind of outdated opinion that Black people do not get MS. We know that is not the case. Next, the incidence. So that's the rate at which people are getting MS over a defined period of time. It's high in MS patients. Black women in particular right now are thought to be those with the highest incidence of multiple sclerosis. So just a few differences. Again, I will be upfront and say research is lacking, but what do we know based on what the information we have? There may be differences in MRI findings. So a lot of you have probably seen your MRI. If you haven't, you should. But the lesions are these white little spots here and over here. Those are the MS lesions. And when we talk about lesion burdens, we're talking about how much abnormal brain or lesion-involved brain there is compared to the not involved. And that's really more important than how many lesions you have. A lot of patients ask, well, how many lesions do I have? You could have 30 tiny ones, and that's going to pale into comparison with somebody with just 5 big ones, for example. We want to know the proportion of normal to abnormal or affected compared to unaffected brain. And so there is some literature to suggest that the lesion burden is going to be higher in Black individuals living with MS. Next is accelerated neurodegeneration. So they've done studies comparing Black and white people living with MS in America, and what they found is that there may be faster brain volume loss. So with age, whether you have MS or not, we expect that there's going to be a certain amount of brain volume loss as you get older that's considered within normal range. MS patients in general tend to have an accelerated rate of brain volume loss, but what they're suggesting here is that amongst Black individuals living with MS, it may be a little faster. Retinal tissue loss, so optic neuritis is very common with MS, and the changes we see with that, how it affects the optic nerve can transfer to the retina as well, and so seeing increased loss there as well. So with both of those, brain volume loss and retina loss is in line with findings that suggest Black Americans living with MS may have a more severe disease course. And the genetics, they're very complex, the genetics of MS. There are hundreds of different genetic variations that have been associated with MS disease, but we know that they have a varying impact because not everybody with that genetic predisposition is going to develop MS. And we see that in clinic. There are a lot of people, the majority of people come in and they don't have a family member that has MS. But every once in a while, you see somebody with 1 or 2 siblings, or 1 or 2 family members, I should say. And then every once in a while, you see somebody with multiple, 4 or 5 people in their family that have multiple sclerosis. So clearly the genetics here are different in how they manifest and how they present. There is some research to show that there is the genetics on some African ancestry is associated with disease severity. But in terms of the highest risk, it's been what they found is that Black Americans with this specific European variation have 3 times higher risk. And so you put all that together and then you look at Black Americans who are going to have so many varying degrees of both African and European ancestry, and it gets really, really complicated. So this is a huge area of research where we do need more information because a lot of the data is not including minority populations. So to just kind of summarize some of these racial and ethnic differences, we see more involvement of the optic nerves and spinal cord. Obviously, that's going to be more likely to lead to some symptoms associated with disability, difficulty seeing, difficulty walking, more frequent relapse. With those relapses, we tend to see less recovery in between those relapses, faster progression to secondary progressive MS. And I'd like to add with that as a whole, across the board, we are seeing less transition to secondary progressive MS, and it is because of the treatments that we have available now. We see more rapid disease course and more disability accumulation. And so going back again, we have to ask ourselves, is just biology or are these differences because of social or economic disadvantages that are disproportionately affecting Black individuals living with MS? So that, again, we need to tease that out and figure out what's going on. So in considering adequate representation in clinical research, we ask the question, is poor representation a barrier to treatment? And it is. It is because there may be factors that influence disease in a certain population of people that we're completely unaware of because they weren't tested in sufficient numbers. And it's also a barrier because you may come to me and we're talking about a treatment, and if you ask me how many people who are Black were included in that study, and I tell you 2.3%, that's not going to go over very well. You want to have confidence in that. So are there differences in responses to treatment based off of race? And the answer is we don't know, but we don't think so. But maybe there is a whole bunch of ifs and maybes and thinks, right? That's kind of the short answer. The long answer is they have done studies in certain medications to look at Black individuals living with MS. The problem is it's always after the fact. A lot of the larger studies don't include sufficient numbers, and so they'll go back and try and do, phase 4 clinical trials or other studies with sufficient numbers. And in those cases, the medications do appear to work or be effective in Black Americans. But again, the goal would be to get that information from the onset. As soon as that medication is FDA approved, we can say with confidence that this medication has been studied in a diverse population. Other potential variances, so differences in mortality. Again, when we think about MS, we don't think about it affecting how many years you live, the quantity of your life. We think about it affecting the quality of your life. So if we do see differences in mortality, we really want to look in and dig into that. Why is that happening? Differences in biomarkers. So biomarkers are going to be like indicators of a disease state, the activity of your MS. So the most common biomarker you all are familiar with is going to be MRIs. You get your MRI, it tells us how the disease is behaving. But there may be differences in biomarkers between groups. So we do research on that. And then differences in immunopathogenesis, which is going to be the process of the disease development itself. So as we talk about research barriers, there are several. Access, which we've talked about a lot so far, is a huge barrier. So anything that prevents access to care, just generally speaking, is also going to affect your access to research. A lot of our clinical trials are going to come out of these specialty MS clinics, for example, and if you don't have your foot in the door at this clinic, you're probably not going to be able to or have the opportunity to participate in research. So other barriers are going to be financial, time, cost. It takes time and they keep you busy in research. There's a lot of visits. And if you can't take the time to do that, or if it's far away, all of those things are going to make it incredibly difficult if you don't have those resources to leave work, leave your home. Safety. A lot of people have safety concerns about MS research or clinical studies, I should say. Am I going to get poor quality care? Are my doctors being forthcoming with me? Are the investigators being honest? Are they just using me to get results? All of that is going to prevent someone's willingness to participate in research, and it's going to be closely linked to mistrust. And it could be mistrust in just healthcare in general, but a lot of it too stems from the history of discrimination that Black individuals have faced in this country in healthcare. That all plays a role as well. Misinformation, I will say lack of awareness and misinformation together. So just knowing what it means to be in a clinical trial, not knowing that, obviously you're going to be hesitant to participate. So making sure we get that information out there is important. And then even with that, knowing where to go to get involved in studies, having that opportunity to be in research. One of the more common areas of misinformation that comes up a lot is that people may assume that in a clinical trial, you may be given a placebo, a non-working drug, and not be told about it. And that's just not true. You will always be told if you're going to be given a placebo. And in fact, with MS, with our relapsing clinical trials, it's not ethical to use placebos anymore because we have drugs that work. And so they usually do what we call an active comparator. So the drug that they're studying is compared against another drug that we already know works, so that no one's on a pseudo drug or a fake drug, that sort of thing. So Jen, this is just an example of that kind of misinformation that's out there. Bias is a two-way street, right? Because you as a potential research participant may have biases towards research itself, and the research team can too. They did there was a study that looked at a survey of different individuals, and they found that Black people weren't asked as much about research or invited less. And so maybe bias is coming from the research team, whereby they're making assumptions this person isn't going to or they don't want to, and not giving everybody the same opportunity to participate. So I always like to go over this, and that this is, there's been a lot of change over the years, and there are protections in place for research participants. There are government agencies, so the Office of Human Research and Protection. So agencies like like NIH and that sort of thing are going to fall under this. And they have a lot of oversight in terms of how they carry out these studies. The FDA is really paying attention to their clinical trial sites. They're doing inspections all the time. So all of these are to safeguard the participants. And then there are institutional safeguards. So wherever you go to get your care with that study, before they are even allowed to carry out that study at that particular institution, the IRB, the Institutional Review Board, has to make sure that that study is ethical, that the inclusion and exclusion criteria are fair, that there's no undue risk to the participants in the study, that they're being compensated appropriately. So there's a whole lot of decision making. If they don't think that things are adding up right, that study will not be approved for that institution. And then there are data safety monitoring boards. They are monitoring that study the entire time. They make decisions about whether or not that study can continue. Do there need to be changes, or does that study need to be terminated? Again, all of that is making sure that you as a participant are protected. And when you do research, you can drop out at any time. I tell people all that time that signing that informed consent does not mean that you need to participate in that study. You're just saying you understand what the study is. So as you look at improving representation in research and clinical trials, the solution really is multifactorial, and we require efforts from everybody across the board. We need to hold our sponsors hold our sponsors accountable to make sure that they are putting in the efforts to ensure adequate representation where they're carrying out these studies and the study design. Our investigators and our research team have to do their part trying to work on diversity in clinical trials, and then the MS patients and communities doing their part as well. But really, one of the bigger issues is just making sure we have equitable health care. By promoting that, people will have more research opportunities as well. I always like to show the National African American with Multiple Sclerosis Registry, because not all research is going to be a clinical trial where you're having studying a treatment that is still investigative. Registries are a really easy, non-invasive way to participate in research. You're usually just filling out surveys, and that provides valuable information to us as well. So this is just an example of that. All right, so improving access to care and outcomes. I just listed a few things that I think are kind of came to mind in terms of what we can do to try to make things better, or that have helped to make things better. I'm about 5 minutes out. So telehealth improves accessibility. So telehealth has been great for a lot of patients living with MS because the frequency of appointments sometimes can be a lot. Concerns come up and it may be difficult to get in for an appointment. And for people who maybe live far away, there aren't comprehensive MS centers everywhere. So unfortunately, a lot of people do have to travel, and that can be difficult. And then difficulty just with navigating, getting, into a vehicle if there's a lot of disability. So telehealth has been really great. There was a VA study, I believe, that looked at this, and MS patients definitely utilize telehealth more than other patients. And so it is improving that accessibility. We use it a lot for check-ins sometimes. And if things are happening, it may not even be directly related to MS, but we're able to give direction to that person so that they're not necessarily having to go as many places to get where they need to be to get the care that's warranted at that time. Next is shared decision making. This has kind of been something that we've been talking about a lot more. I think it's particularly relevant with MS because of the amount of therapies and treatments that we have right now, but really it is you living with MS and your neurologist or physician working together to make decisions. It's not the patient saying, I'm only doing this, and it's not the doctor saying, this is what you're going to do. It's working together. It's the patient understanding from the doctor, I'm going to hear what you're saying, and I trust that you're going to do what's best for me. And it's the doctor saying, I've invested enough in knowing you that I want to know about, or it's relevant to me how you feel about this. What are your fears? What's going to work best with your lifestyle? All of that coming together. And so what they find is that when we utilize shared decision making, especially as it relates to MS treatments, because we have a lot right now, we're able to be pickier with how we do that. that the decision is going to be less overwhelming for the patient, and the patient's also able to gain a lot of knowledge and understanding of the disease and why they're taking what they're taking. So again, it's a good process to have in hand. And again, it's on all parties involved. So that means you as a patient have to speak up and say, this is why I don't want to do this, or this is what I'm concerned about, and not just say nothing. And then maybe you go home and decide, I'm not going to take that treatment. I don't like what I heard about it. You have to voice all of those things. And then you want a doctor who listens and acknowledges that as well. Advocacy is another one. So I'll start with self-advocacy. That means speaking up for yourself, letting your concerns be known. If there's something you don't understand, ask about it. Doing all of those things so that you're able to advocate for yourself for the best care. If you don't know that there are certain services or resources out there, you may not know to ask about them. And that's what we want. You want you to try to use the services that you need. And then there's systemic or health advocacy, where we were really talking about supporting policy change. This is helpful, for patients and us as well to get involved. Telehealth, for example, I'm not sure if some of you know, but they changed this recently where we can't do out-of-state telehealth visits. It makes a huge impact on a lot of our patients who are out of state, that we can't use telehealth anymore. And so that's just one example of where advocacy could be helpful, where we go, and it varies state by state as well with some of these things, but that's something that we'd want to change. So there are a lot of what I would say are inappropriate guidelines sometimes that are in place through insurance and other things that we want to work on changing on a systemic level as well. And then health literacy, that's important. I would say all of you here are doing the right thing. You're here, you're trying to learn about these things. So I would charge all of you too to kind of spread the word to people who may not know, because the more people are familiar with navigating their health and their MS, again, the better that they're going to do. And I'm going to end with comorbidities that can impact MS. I bring this up because there are certain comorbidities that disproportionately impact Black and African Americans. So cardiovascular risk factors, these are really prevalent, MS or not, but we know that they can contribute to MS disease progression, the first 4 in particular. So it's important that you take care of your whole self, okay? When we talk about hypertension, again, really common. Generally speaking, all of the cardiovascular risk factors as well are going to increase your risk of stroke. And when we think about lesions and stroke and MS, it's not good, right? If you look at lesions in general, a lot of people have brain lesions. Majority of them do not have MS. So these cardiovascular risk factors can cause lesions as well. If you already have lesions or damage to the brain from MS, we don't want to add to that with that. Hypertension is more common, about 25% more common in people living with MS, and it's more common in Black people, and it's more likely to be uncontrolled in Black people. So that's a comorbidity that we really are working on just across the board to make sure it's controlled. I encourage all of my patients, make sure your blood pressure is good, okay? Because that's going to impact your MS. High cholesterol, we want to make sure that's addressed. Tobacco use is associated with disease progression, larger lesions, so no smoking. Diabetes is going to be more common more common in the Black population, and it's more likely to be uncontrolled in the Black population. We also see more diabetic complications like renal disease, peripheral neuropathy, eyes, vision, and peripheral neuropathy and vision. You think about that and what it can present as, there's going to be a lot of overlap sometimes with MS symptoms. And then lastly, obesity is also tied in with disease progression. And this is my last slide here. I just want to talk very briefly about mental health, okay? MS does have higher rates of anxiety and depression. If you look at, studies looking at this as well from a social and economic standpoint, those with social and economic disadvantage have higher levels as well. But just within the Black community itself, there's still a lot of stigma related to acknowledging and treating mental health. But that's a huge part of living a good and life, a good quality of life with multiple sclerosis. So just acknowledging that and working with others to try to combat that stigma. All right. And that is the end of my slides.
Okay, great. Thank you. Thank you very much. And then, what else? And then we have now Damian Washington coming online, all right? And Damian Washington is our patient advocate. Damian's been very active in the MS community, well, since I think just before COVID, when it was that I first met him at a conference. And he's just been very active with the MS community since. And he's not just involved with what he does for MS Views and News, but he is active with other organizations as well, because he's just trying to get the word out there for as many patients as he can. So we want to thank Damian. Oh, there he is. Look at that. Do you all know him? You ever see him before? Nice, good looking guy. You know, he left the United States to go live in Spain. Wow. Everybody's saying, wow, Damian. We lost the feed, Bill.
Yeah, it's
All right.
1:30 in the morning.
1:30 in the morning. See that? And he's here to talk with you all. So Damian's going to have a conversation with Dr. Rosenthal. And then after their conversation, we're going to go to Q&A. All right. Thank you.
Hi, Damian.
Dr. Rosenthal.
Before I start asking you questions, was there anything that caught your attention from the slides?
I think it cannot be underscored enough the health disparities that come along with the population, and so it can be things all shapes and sizes. So yeah, it's the medical terminology, it's the figuring out drug prescription benefit, and your health insurance coverage and consent forms, the way the language can be broken down. There's so many different facets that are just unequal. The level playing field, that's not really a thing in popular society. And then the more segmented and the more specific that you get, it gets that much more small and that much more specific. And having a central nervous system condition where it's eating your brain and your spine is one of those terrible spots to find yourself. And especially when you know you're not going to get this same shake as everyone else.
Yeah, couldn't agree more. Okay, so my first question for you is, have you dealt with any negative experiences with your interaction in healthcare?
Personally and directly, I feel as if I have not, and I've been lucky in that. However, you see the type of person I am. Like, I'm up at 1:15 in the morning to talk with MS patients. And I have a YouTube channel that has 7,000 subs, and my Instagram has 10,000 subs. So I'm quite active. I don't take no for an answer. I showed up at my health insurance offices when I got a $68,000 bill with a camera. And I did not leave that place until I got an answer which satisfied me. And in the end, once they figured out everything, and because they took the time to try to do that because I was there, and once they figured everything out, they said, "Oh, okay, sorry that happened, my guy. Don't come here again." Like, straight up, that's on my YouTube channel. So yeah, it's one of these things that you really feel that you shouldn't have to do because you have your medical condition on top of everything else, on top of the phone tree, on top of the bills. That's unimportant. What is important is that you get the best care that you can for yourself, because you're the one with the medical condition, not the doctor, not the health insurance people. You are the one who has to figure out what it means for yourself.
And folks, that's what self-advocacy looks like, all right? Perfect example. All right, Damian, what is your outlook on research, and has it changed or evolved over time?
It has evolved over time, because I know I'm getting more emails and I'm being on more patient groups, and I'm having more thorough conversations about how to evolve these. In fact, I cannot remember the company specifically, but I was involved in some research and some patient understanding, and that study just came out today. So they patient, not advocacy, but patient involvement and patient inclusion has begun to really expand in ways that were not present 5 years ago, certainly 10 years ago. And I became active on the MS space 7 or so years ago. And so I've been a part of that expansion. And it's just nice to see how it has gotten more robust. And I'm looking forward for it to be that much more robust. And that's what people like you and folk like myself and everyone else in the room who are getting more information are out to do.
Yeah, absolutely. All right, we talked a little bit about shared decision making. What what are what does that look like to you? This whole shared decision making concept.
I mean, there's no words because like ultimately it's my decision. So let us figure out a way that we help this that we can make this come out together. And your doctors, they're your teammate. Your spouse is your teammate. The people around you are the teammates that help you run the plays, but it's your team. You got to score the ball. So because you're the only one who has to live with it. So shared decisions are important because it helps expand beyond what you can specifically see, and you might not be able to see things because you're so close to it. But it is important for you to figure out how to expand and broaden your decision making with the people around you.
Yeah, absolutely. All right. What advice would you give to someone who was recently diagnosed and now just learning how to navigate this process?
Give yourself grace. The medical condition is so individual. Your MS does not look like my MS, does not look like the people in the audience MS, et cetera, et cetera. So give yourself grace to know that this is yours and you have to figure out your own way around it, whether it's this diet or that diet or exercise more or you go to sleep more. Whatever it's going to be, it's going to be something that you have to find for yourself and you have to put that legwork in. And yeah, it's not that fun a lot of times. That's why they call it work. So do the work and you reap the rewards and the benefits in ways that you cannot currently see. That's the most important thing. There's wellness out there for you that you cannot currently see. And so it's important for you to stretch yourself beyond what you think you can do within reasons, of course, so you can reach places that you did not think were possible.
Yeah, that's good advice for someone that's new or has been living with it for a while. That's sound advice across the board. Well, Damien, do you have any questions for me or any other comments?
Pardon?
Do you have any questions for me?
Why neurology? Why multiple sclerosis patients? I mean, you took all of that time to become a doctor, and then you were like, "Ooh, I'm gonna be a brain doctor." And then you were like, "Ooh, I'm gonna be an MS brain doctor." Ooh, like what is that process? This is me being silly. That's kind of what I do. But what has informed your decision to be a neurologist and specifically a neurologist for MS patients?
Yeah, I do get asked that quite a bit, and it wasn't a straightforward decision. Neurology, that part was kind of easy. I like the brain. It's very it's like a map and I can make it make sense. If you, from an MS standpoint, if there's a lesion somewhere, and you have a symptom, the fact that I can link those together, I've always liked that. And that's a lot of neurology, whether, different disease processes have that. But I did not go into MS right away. I practiced general neurology for a period of time. And I was in the military at the time. I was Fort Benning, which is now Fort Moore, for those of you who don't know. I was a neurologist down there, and a lot of my MS patients patients, with them being in the military, after I diagnosed them, they were relatively quickly medically discharged. The vast majority. I had one or two that were able to stay in because they had minimal symptoms, but I missed them. And after a while, I said, "This is what I'd like to do." I like the patients, and this was about 12 years ago, and there was a lot of medications that were starting to come out, and so that's really one of the primary drivers to me separating from the military and doing the extra studying in neuroimmunology and being able to do MS right now, and I'm so glad I did. Yeah.
Cool. And one more thing. What do you wish more patients did? Like that is a thing that is always sort of on my brain whenever I deal with medical professionals and have a rapport and we have an exchange. It's like, well, what do you want folk to do more generally than not? Like what do you suggest people do?
I really like an active participant. I like it when we feel like we're making a decision together. When someone says, "You're the doctor, you tell me what to do." I mean, sometimes I can do that, but sometimes there's more than one way to approach it. And I do want your input. And so that and just someone being able to honestly come in and verbalize what their problems are to tell me, that helps me feel like we've accomplished more, and I'm sure it helps the patient feel like they've accomplished more too. So that would be my advice.
Absolutely. No, that's wonderful. Thank you for sharing that and for giving more information about these sorts of things. Because I'm curious. Curious minds want to know.
Well,
And thank you
thank you.
for showing up and expanding upon these areas that really kind of get overlooked and giving more information and more clarity to them. And shout to Stuart, shout to Bill, and shout to everyone in the audience right here, right now.
Thank you.
This
Thank you.
difficult work, and this is a special time. Respect and please and thank you.
Thank you.
Thank you. Damien, I have a question for you from the audience, not from this audience, but the online audience. They want to know what you tell patient advocates, patients with MS that might come to you and say, "I'm having a problem getting my doctor to listen to me." What do you tell them to do? They're afraid they don't live in an area where there's plenty of doctors around, and they want to know why they have to listen to their doctor, or what would you tell them to do to get them to listen, to get their doctor to listen to them?
That was the first thing I'd say. I'd be like, get a new doctor. But
But they don't live in an area where there's a lot of doctors. So now what?
yeah. See, so that's the thing. So if this is your one-stop shop, right? You have to sort of figure out what specifically is not getting answered. Is it sort of like a catch-all? They don't listen to whatever I say, then that's one set of solutions. If they kind of dismiss the findings that you bring, like, oh, hey, this is something else that I saw. What do you think about that? Or there's so many different ways to slice this pie. But if your doctor isn't listening to you, that's really where I'm just like, find another doctor. And if that is not really possible, it's sort of like, now you get to be frank. It's like, yeah, my name is Damien, but I'm also Frank. So I'm paying my copay. I'm saying it with my chest right now. And so you don't have to really be that aggressive. But when you are looking someone in their face, in their eyeballs, and you are really being vulnerable and saying, I need something else from you. I need something more. Help me figure out how you can give me what I need. Because I gave the money. So yeah, I gave you what you need. So, sir or madam, let's figure out a way that we can figure out a general consensus. Oh, because my immune system is eating my brain and my spine, and it's terrible.
Thank you, Damien. Making it nice and colorful. The audience is clapping for you, okay?
Yeah, no, I hear it. Go ahead. That's what it is. I appreciate y'all. I can't see none of y'all.
He can't see you, so let him know that you're here, right? Say it out loud. There you go. Did you hear it?
Not a little bit, just
A little
'cause it
bit. Well,
it
that was
didn't.
loud. It
Yeah,
was
no,
like being in the.
I
It was like in the middle of being in Atlanta
felt it.
Stadium. All right.
I couldn't hear it because it went all the way up to
All
space.
right.
When it
There you
came
go.
down to space and over in Spain, it was a whole nother thing. However, I feel these vibes because I
All
say
right. Let me ask the
multiple
patients if
sclerosis
they have
is
any
a
questions for
terrible
you.
way to meet wonderful people. So whenever people join, I just feel that extra energy because I know they're dealing with something that they would rather not deal with. And I know I've been there. So I just always aim to give my all to patients and people who are concerned with patients. So really, thank you.
Thank you. Anybody have a question? All right. Hang on a second. You have a question too? You have a question too? Rhonda, I'll be there in a minute. In front of the microphone. Lucky the sound didn't blow out.
Okay. Hi, Damien. My name is Angie.
Hey, girl, hey.
Hi. All right. I am a MS warrior, and just wanted to know how long have you been in Spain?
How long have I been?
In Spain, been living there in
Oh man,
Spain.
I can't hear it. How long have I been?
In Spain. How long have you been
insane?
there?
Most of my life. Uh, and I'm also incredibly smart. So I once I figured that out, I use it to my advantage, and I use it to further what my needs, and I also use it to further the needs of folk around me who are less insane. So everybody gets to ride this wave, baby.
All right. We're on for the next one. So we're going to take just two more questions from Damien. Then we're going to say nighty night to Damien so he can go to bed. And then we're just going to go on and ask questions with the doctor. Okay.
I'm sorry, Sue. I prematurely raised my hand, but it wasn't for Damien. It was
Well, then
more so for
we'll
the
come
doctor.
back to you in a few minutes. All right. Anybody else have a question for Damien? One more. Loud.
Hi, Damien.
Hey,
Tell
girl,
me
hey.
what you do, or if you do anything to encourage people to get involved in clinical trials.
Yes. Um, what do I recommend to do, or what do I do, or what?
Both, okay? Both.
Huh. So
Both.
there's various websites out there. I don't have any of them offhand right now. I just got off of that was dealing with all of this, and so I don't have those notes right in front of me. But
She only
there's
want to know, what do you do to encourage patients to get involved with clinical trials? What do you do to encourage patients to get involved with clinical trials? You need a big mouth like me. Big mouth.
ask their doctor if they know anybody or they know any trials around. Ask other patients. Once you're sort of in um, the mix, we cool. So if you have a relationship with people, you build relationships with people, become active in the comment sections, and eventually you'll find one person leads to another person, leads to another person, and that will have the info that you need. It's really a community driven sort of a thing. And one person knows the next person, and by the time you get to the fourth person, you'll find what you need.
All right. Thank you. Let's say goodnight to Damien. Damien, thank you for
Thank
coming
you.
online. Namaste.
Thank you. Really, it's thank you for showing up for yourself. Respect.
Great. Great. Thanks. Good night.
As it relates to the trials, for someone like myself who was diagnosed a long time ago, oftentimes there are no studies for people like myself, who've been diagnosed so long. So are there going to be more? Are they looking at some ways to still make us a part of being able to participate in trials?
So you're right. A lot of these trials are just ageist. A vast majority of them are going to enroll up to age 55 and sometimes 65. And truthfully, it's because they don't want age-related factors to impact the trial outcome. Now, they're with not everything's a medication and not everything's a disease like an immune therapy. So there are other medications sometimes that aren't going to be as strict with the age. And then there's non-medication trials. So things looking at certain types of exercise or therapies or certain devices that may for walking and that sort of thing. So there are a lot of options. So it may just be not necessarily looking for just, the latest, greatest, newest immune therapy, but looking at other ways that you could contribute to research that aren't drug related.
All right. So, question came in from online that she is 56 years old, and for whatever reason, she had to stop using her current therapy, some kind of illness that she has. And when she asked the doctor, "What can I go on to next?" they said nothing. And she said, "Why nothing? I'm only 56 years old, and I need to be on some kind of therapy." And that doctor told her, "Because you've aged out." What would you tell a 56-year-old that's been stable for a number of years who may tell you that they're trying to get her off of therapy?
So not again, one 56-year-old with MS who's been stable for a number of years is going to be different from the next 56-year-old, from the next 56-year-old. So it is highly individualized when we take people off treatment. We do eventually take the majority of people off treatment, but that time point varies for everybody based on disease activity, based on medical comorbidities, based on lifestyle. So there's a lot of things that contribute to that. So when I hear that story, I hear of a patient who was told to get off treatment and there's not a complete understanding of why. And that's where that whole, advocating for yourself and shared decision-making and all of those things. Because when I do take someone off treatment, it's rare that I'm like, you definitely have to come off right now. I may want them to come off or feel like that's necessary. But after I tell them why and explain it, then they're like, "Oh, okay, I see where you're coming from. I should be off therapy." And that's the piece that sounds like it's missing potentially.
Thank you.
All right, my question is two-part. Do you need your physician's approval to participate in a clinical trial? And when you're involved in a clinical trial, do you have to stop your current medications?
So do you need your physician's approval to be in a clinical trial? Yes and no. You need the physician who is in the investigator, the person that's enrolling for that clinical trial. Obviously, they have to be on board. A lot of the time, the principal investigator and your physician may be the same person. Ideally, you would like your physician's blessing because that means that they think it's a good idea for you. There are lots of clinical trials that I've had patients ask me about, and I say, this is not the study for you. And I think it's important to have that relationship with someone where you can rely on them for that guidance. Your second question, if you get in a trial, do you have to come off your medication? It depends on the trial. It's different. As of late, there's been some trials looking at add-on therapies. Okay, so it depends on, and they're adding on to certain therapies. So it's very dependent on what they're looking for, what they're looking at, whether or not you have to come off medication. At the end of the day, though, no one's going to enroll you in a trial or take you off a medicine that's working to put you on something that you don't know if it's working. That wouldn't make sense.
Same question, Dr. Rosenthal. What do you do to encourage people to get involved with clinical trials?
We talk about it. We talk about it, and we talk about I think that sometimes it's not emphasized enough, the benefits to you as a patient in a clinical trial. Sometimes people have exhausted all of the possibilities, and that clinical trial is an opportunity to take a treatment that otherwise would not be available. It varies so much from person to person. Clinical trials have provided advantage to people who may not have the insurance to pay for a medication. And I'm not even talking about an experimental medication. There are clinical trials that are for medications after they've already been approved. And so just by being involved in that clinical trial now, you're getting essentially all of your MS care covered under that. So there are advantages in that way. But really, we just, again, I try to let patients know it's completely voluntary, try to be upfront about it. We go back and forth a lot. Sometimes I invite patients into clinical trials and they're not interested. Sometimes they ask me about it. And like I said, it's not appropriate for you. But a lot of it is just knowledge, understanding, just talking about it.
Person wants to know, why was there a biosimilar approved and yet it's not available in the United States?
So my, I'm not sure if I'm thinking of the same biosimilar the question is about, but still with the United States and the FDA approval process, if it's not approved here, it's because it's probably making sure safety and that sort of thing is in line. There are medications that do get approved elsewhere that aren't necessarily going to be approved here, and it doesn't always match up. But I just will say, with medication approval here, even though, like I said, with the biosimilars, because they're not identical, they're similar, they have to have all their ducks in a row. Safety needs to be key. Monitoring needs to be key. And if all that stuff isn't lined up right, it's going to hold things up.
So this one was FDA approved as a medication, but not.
It is. You're right. It is, but
That's right.
it's because of the safety protocol, the REMS protocol, that sort of thing. So safety, the monitoring piece of it is not quite where it needs to be just yet, is my understanding.
Okay. All right. Next, if a patient comes to you and has problems with taking a high efficacy medication that you would recommend, and they are concerned about the side effects of that high efficacy medication, what do you then suggest?
So if I've done all of my part and I feel like I've adequately educated you on that medicine, and we've talked about the risks of taking it versus not taking it, and I feel like you have all the information you need to make an informed decision, and it's your decision to not take that treatment, then I would say, what treatment are you willing to take? I just want my patients to be informed. If you're going to make a decision that I don't necessarily agree with, I just don't want there to ever be a time where you look back and you say, well, I didn't know. And so if someone doesn't want to do the treatment that I recommend, I don't just say, okay, well, you don't want to do what I want to do, so bye. I do what you're comfortable with, but I'm going to make sure you have all the information you need to make that decision.
Great. Thank you. Anybody have any questions here yet? Nope. All right. I'll keep going. All right. We got a few here. When it concerns telehealth, people want to know that if they live outside the Atlanta area and it's not possible for them to get to the Atlanta area because of a lack of transportation coming out of rural America or the rural areas outside of Atlanta, and they don't have anybody to take them here to see somebody at the Shepherd Center, but they want to know if you will do telehealth with them.
So it's important that a patient is seen at least at some interval in person. We need to see you in real life, place our hands on you, do an exam. That's an important part of following somebody with MS. But there are certain patients I may see 4 more times per year. Do I need to see them in person every time for that? Absolutely not. And so only telehealth without ever seeing someone in person isn't necessarily feasible. But we certainly utilize telehealth right now while it's still allowed for people who live outside of the Atlanta area. Again, there's constantly changes coming. There's some Medicaid changes coming. So I'm just hoping that we're still able to use it because it really does help with access.
Okay, thank you. Another person wants to know if they're not comfortable in going into an infusion center and they need to get infusions, is there some way that they could get it at home?
Some people do offer home infusions. Ultimately, whether you're a candidate for it's going to be up to your doctor, but they are offered.
The person is writing about comorbidities. What are the most common comorbidities there are with people of color?
With MS and people. So I covered a lot of them, and that's going to be those cardiovascular risk factors that comes up a lot. Autoimmune disease, other autoimmune disease tends to happen not across the board, but there's a little preference towards African Americans, Black individuals. We are seeing that it's not just MS. We're seeing that in lupus and other inflammatory or systemic autoimmune disease. Disproportionately affecting. Those are the main things that are coming to mind right now.
Okay.
Yeah.
Can a person with MS have a similar autoimmune condition
Similar to MS?
similar to MS? Can a person with MS get lupus?
Oh, absolutely. We see it. So if you have one if you have one autoimmune disease, you are at higher risk for having other autoimmune disease. We have a lot of patients that have MS and Sjogren's, MS and rheumatoid arthritis, MS and lupus, MS and psoriasis, MS and Crohn's. We see it all the time. And we have to work with our other specialists in order to make sure, because it's multiple immune therapies sometimes, so we try to simplify that. And we even see that in family histories, right? Maybe not everybody has MS, but mom may have rheumatoid arthritis, the sister has another one. So it's like different flavors of an autoimmune disease. It may not all look the same.
Thank you. That being said, how do you test a person to have a similar autoimmune condition that has similar symptoms?
So usually you start off with blood tests, and it's based off the symptoms. You would talk about it with your doctor, and they can get that test done.
So we want to thank Dr. Rosenthal for coming to speak. Yes?
Thank you so much.
Thank you very much. And again, we just want to let you all know that we are sponsored by Novartis and TG Therapeutics. And have a good night, everybody. Thank you.